One example of that is from the early part of the noughties. This is the creation of a bladder by Anthony Attar's group in Wake Forest, using a collagen scaffold seeded with muscle cells on the outside and urothelial cells on the inside. These are small patches in premature babies, so we're not talking about large areas here. Nonetheless, he's been able to restore some degree of bladder function to babies who otherwise would not have had it, in about 20 or 30 cases. He's also started doing this in adults and has had 2 or 3 successes as well. So this is here and now. This is treatment that's already with us. So we started to look at the possibilities of doing this for airways, for pigs, and although it's all very much the same, this is the best one here because it's got epithelium and cartilage. We found that by using just scaffolds on their own, you get some degree of epithelial growth, but it's never perfect, and it doesn't have biomechanical strength. By using cells which have, can lend you biomechanical rigidity, like cartilage cells, and also by having epithelial covering which protects it from infection, you then have something which is a viable, or at least in animals. And apologies to everybody who's probably seen this already. So we were developing this up to an early preclinical level. In fact, we weren't expecting to do a human, but a woman came along in what was called a compassionate use setting. She was 31, she lost the use of her left lung due to tuberculosis and scarring of the airways. She had multiple procedures and really was at end stage and spending her whole life in hospital. There were no conventional options left. Her trachea had been shortened by previous surgery to the point where it was pulled up on the aorta and closing it over. So we took some of her bone marrow, and we also took a donor trachea from a transplant donor and stripped out all the cells using detergent and enzymes. So we took bone marrow and isolated the cells. We also took some nasal and some airway cells and grew them up into epithelium, using techniques that we'd actually developed to try and make grafts less tolerant to more tolerant. Then we put this in a bioreactor, and within 4 days we had confluence. We had confluent epithelium on the inside and confluent chondrocytes on the outside. It had very good biomechanical properties. We were able to stretch it to fit at the proximal end and narrow it to fit at the distal end. In fact, we probably stretched it a bit too much because she did later on develop a small stenosis at the proximal end and required stenting for 6 months. And some people have viewed this as a failure, but if being a failure means that you can work full time and look after 2 kids at home and not have to go back into hospital again, then that's good enough for me. So where next? Well, we would like to move on with this, obviously. So having moved here, we're now setting things up so that we can have appropriate GMP facilities to do this. We were talking about why we've not done another one immediately. That is because if you do compassionate use cases, provided you've got appropriately accredited facilities, you can do them straight away. They are few and far between. If you want to actually plan to do cases, however, that immediately becomes a clinical trial, even if you're planning to do 3. And to do that requires going through the whole MHRA process, which I'll show you in a minute. But we would like to move into children too, and it's likely there will be compassionate cases here that we can tie over. It's easier in a sense because it's only a smaller area. It should revascularise a lot better. It's more difficult because we don't know whether it will grow. And that's important. There are major challenges ahead for surgeons and for regenerative medicine. These are some of them. There's a big hole in funding. We have an MRC, and these slides all apply before the credit crunch. Of course, it's all very, very difficult. Now, an MRC which is run by basic scientists and translational boards which really aren't interested in getting out new treatments in the future. And they stop about this level, the early preclinical level. And at this level, we have the NIHR taking over with its phase 3 clinical trials, maybe a few phase 1-2 clinical trials. But in the middle is a huge area which is not fascinating science. It's very repetitive. It's not something that excites the MRC, and it's not something that NIHR are prepared to pay for. Big pharma won't buy into it until it's approved in therapy, and there aren't enough biotechs with sufficient capital resources to support this. So we do have a hole, and we have to negotiate this. It's another reason why it takes a long time at the moment. So this is the regulatory structure. There's actually a web-based version of this, which is slightly easier. But this is another reason why it's taken so long to get to moving into more patients. Clinical trials are around here. and we have to follow down this route here along here to get it to where we want to get to. We need infrastructure. This is a big issue. Again, we were talking about this just now. You not only need a clean room, you need an appropriately accredited clean room. And if you're going to do any significant number of patients, you need multiple clean rooms because they have downtime, you need grading, you need to put a number of products through at any one time, and may want to put more than one product through. There are very, very few places in Europe that can do this. We are equipped to do that here. You also need appropriate paperwork, and this is changing all the time. It's an area where the ground rules are changing, and you need to keep upgrading at immense expense. We need to train people, and I would encourage lots of our brightest juniors to consider regenerative medicine as an option for their time in research right now. I think it really does have a future. I know we've heard it before, that gene therapy may not hit the heights we hoped it would do, for example. Nonetheless, I really do think regenerative medicine is here to stay. It has so many different arms to it that I do think this is something that we, the colleges, the various peer-reviewed funding bodies, and others should be strongly supporting to build a fit-for-purpose workforce for the future. Technological improvements are coming along, some very exciting ones which you're going to be hearing about shortly. There are very few products available right now. These are early days, and these are usually in areas where immunology is less important, so blood, for example, blood products. It's not a standard of care solution for anything at the moment, and we need a lot of this. And we can also only produce small quantities of product at the moment until we get big pharma buy-in to some of our early successes. An example would be wound products, which are obviously have been in use for a long time, but wounds take a long time to heal. If we had a new tissue engineered product, it would be an expensive product, very expensive to produce. But the National Health Service may be structured in a way that will allow us to produce expensive things because we can actually look at the long-term gains that will be made. And in a lifetime of somebody whose wound is healed straight away and doesn't have to keep on having these dressings, the costs are made up. Plus this person can return to society, can become a productive member of society. These are some of the examples of phase 1-2 trials that are going on just at UCL. We'll be hearing a bit more about some of this. But one swallow does not a summer make, as we're hearing. It's easy to build a career in one patient, as I'm doing my best to do. But we do need more. We also need time as well, because I cannot tell you right now that the woman that we implanted in 2008 is not going to stenose up further, that she's not going to develop further problems, or for example that the stem cells may not develop teratomas. We don't think so because there have been over 10,000 people who have had mesenchymal stem cell therapies and none of them have developed teratomas, so, but it is a theoretical risk. We also need to prove efficacy in the long term too. And these are big hurdles. As surgeons, and academic surgeons in particular, we are uniquely positioned, as I say. We're uniquely positioned not only to understand what the patient needs are and what the unmet clinical needs are that conventional medicine really is not delivering. We're also, I think, well positioned to interest scientists in our field and bring them together so that we're not standing alone in this bridge, but are actually conducting people going both ways. These are people I've worked with, some of whom we'll be hearing from shortly. And embarrassingly, my own major source of funding at the moment is from the US,